notes in this disclaimer. It says that these webinars are in no way designed to be medical references for the diagnosis or treatment. I'm trying to get my mouse here. For the diagnosis or treatment of medical illnesses or trauma. And really, folks, the idea behind this, and I know most of us, especially if you're over 50, we've been raised to believe, well, just live the life the way you need to live it, and if there's a problem, you go and see the doctor. Well, that is becoming very, very outmoded, and really it's becoming a dangerous philosophy to have. And our goal is not just to help people find answers, and really that's is actually debasing to think of what we do in that regard. We are not just looking for cures. We are not even just focused on prevention. Our focus really is on building strength in your body, in your mind, and your spirit, because as we said, the environment in which we live in today is a hostile environment, and you've got to know what it takes to strengthen, to protect, to enhance your body's ability, especially your immune system. And in this country, this culture we live in, the immune system of most people is subpar, to say the least. And so our focus again is on building strength. And to build strength, you really have to start from the beginning. Knowledge, understanding, how to apply the knowledge that is out there. And really there are tons of knowledge out there, tons of information on the websites and in books and everywhere. How do you make the most of it? And so knowledge is where we start from, and that's why we do what we do. We've sort of organized our approach to the physical aspect of our instruction, like the body, the health of the body. Remember, we focus not just on the body, but on the spirit and on the mind as well. But when it comes to the body, there are about 7 major things we look at it. These 7 things we focus on, and whenever we get a speaker, whenever we approach a speaker or a presenter or a healthcare professional to speak to us, we kind of look at these 7 things, and we ask them to deal with one or more of these various aspects. If you remember last week, if you were on the webinar with Dr. Steve, he focused on number 3 right there, biomechanics, which is, well, he's a chiropractor, and we're looking at the spine and the importance of posture, alignment, and balance to the health of our organs. So these are the 7 main areas. And really, if you begin to understand these, if you're working with these, and again, you can go to our website, and we've organized most of our tools and resources along these lines. When you begin to understand these things, then you will be included amongst those who we call healthy people. And in these 4 points you see in front of you, what I call the profile of a healthy person. And of course, it starts with the mind, it starts with good nutrition. It also involves being proactive, knowing what is out there, and knowing how to protect your body, and knowing how to increase your body's ability to function. And of course, an intelligent collaboration with the healthcare system. And I have to say this, if most people, I would say if 50% of the population knew about these and was working and had this practice on a day-to-day basis, I would have to say about over a quarter of healthcare professionals would be out of business. I wouldn't include our speaker today because he just has so many degrees behind him. So if the healthcare field doesn't work, which I doubt will not happen, but he has so many areas that he's involved in. He's a very, very intelligent man. We are really honored to have Dr. Kulisz to join us for this webinar to speak about a very, very important topic. I mean, I had no idea how important it was until I began to speak with him. So thank you, Dr. Kulisz, for being on, and Sherry is going to introduce you right. Well, go ahead, Sherry.
Okay. All right. Dr. Andrzej Alexander Kulisz is a native of Poland who immigrated to the United States in 1980. He specializes in natural health, the application of physics and mathematics in the development of non-invasive treatments, and the development and management of clinical studies. He has a strong interest in non-surgical and drug-free treatments, homeopathy, general naturopathy, and treatments through general fitness, nutrition, education, behavioral modifications, and patient participation. He sees the application of basic science to medicine, the growth of naturopathy, and nutritional treatments all play important roles in accomplishing this goal. He also stresses the importance of patients' learned and active participation in their treatments. Dr. Kulisz is a licensed naturopath in the District of Columbia, is a physician specializing in natural health, accredited in all countries of the European Union, board-certified American Association of Drugless Practitioners, and board-certified American Alternative Medical Association. Boy, that's a mouthful. Dr. Kulisz has his practice and lives in Tulsa, Oklahoma. So, Dr. Kulisz, are you there?
Yes, I am. Good evening, everybody.
Good evening.
Okay, well, let's start. We'll be talking today about incontinence, and just a note to our listeners, we are broadcasting today via Building Strength webinars. It is our first appearance, appearance of the European National Health Center that sponsors this broadcast. We'll be talking about incontinence, and the subtitle is "The Secret Women Do Not Want to Talk About But Should." Well, I spent quite a bit of time researching incontinence and eventually developing treatment programs and instruments. And eventually, as a result of this, I traveled quite a bit from London, probably from England, from one of the most prestigious Bristol Urological Institute, all the way to Singapore, through many countries of Europe and Southeast Asia, teaching elements of incontinence treatments and elements of female urology that has to do specifically with incontinence. So why is it that this is a secret women do not want to talk about but should? Well, about 90% of incontinent cases, maybe even more, are cases that women have. Men rarely have incontinence, and as you're going to see, let's set the stage here that women see doctors after they become incontinent, and men become incontinent after they saw doctors. This basic rule. And I have it here. I mentioned this first time in 1995 during Dutch, when I had a talk to one of lectures at the Dutch Urological Convention, and this gave me quite a bit of ovation there. It's probably a very good indicator that those doctors that were there agreed with the point. So let me talk about it in a slightly different way. Let me put some statistics here on the screen so you are going to see the prevalence of it. In 1996, there were about 13 million Americans that were affected with incontinence, urinary incontinence. Well, right now, there are no specific, we did quite a bit of research to update those slides. We didn't find anything other than we have been, basically, what we found out was that this number probably about doubled by now. So it's somewhere about 25, 26 million Americans that have to deal with incontinence. When it comes to prevalence among different populations, it's about 5% are men and up to 30% are women, somewhere between 10 to 30% depending on the age. And there's a very interesting thing that you're going to see in the next point, that about 28% of female exercisers are incontinent or have incontinent episodes, and those exercisers are somewhere between 18 to 21 years old, and only 26 of those that are 30 to 59 years old. I mean, the difference is quite small. It's about 2%, so it may not be statistically significant. Nevertheless, the point is that younger women have a lot less healthy lifestyles than those older ones, and very often this reflects on incontinence, and we'll have a time we are going to address this point. Let's talk about definition of urinary incontinence. Generally, it is said that this is loss of bladder control. It is a symptom. You are going to see different opinions about it, and this has to do with arbitrariness of how urinary incontinence is perceived. I consider it a symptom. It is caused by lower abdominal surgeries or injuries. It is caused by spinal cord injuries, usually quadriplegia or paraplegia, some other neurological disorders, multiple sclerosis, infections, interstitial cystitis. And the interstitial cystitis is an element that we will be talking about because here in the United States it is considered to be non-curable, while indeed there are ways to take care of it, and those ways that we do in Europe. So what is exactly the stress urinary incontinence? Well, it is very elusive, and it really depends on the point of view of the person. If the person is a strong individual and has a goal, has dreams, then urinary incontinence is more of a nuisance that they live with and they move on. Those people that are of weaker mental constitution, then this is becoming a problem, leading very often to depression or very heavy depression, very deep depression. Stress incontinence is divided into three types, depending on severity. There is a fourth type called intrinsic sphincter deficiency that is indeed probably the most severe way or most severe form of stress incontinence, which would make it type 4. Nevertheless, that is classified separately. Another one is urge incontinence that may or may not have neurological component to it, and mixed incontinence, obviously, combination of all those above. There is another type of incontinence called overflow incontinence, and depending on the point of view, I would rather classify it as retention, as urinary retention. The incontinence manuals treat it as incontinence, while in fact what happens is that when people are retentive, they cannot empty their bladders completely. Those bladders are filling very, very quickly, and patients with this condition are basically dripping urine all over all the time, so that's why it is called overflow incontinence. Now, all this said, you see the last item on the slide, arbitrariness of definition. Once again, it is a perception of the examining physician, perception of the patient, perception of the family of the patient. So a lot of this depends on individual point of view. To continue with the next slide, here is the definition that I put in completely, in its entirety on the screen, so those of you that are watching it probably will have a better and more academic understanding of it. That it is stress urinary incontinence is a dysfunction where a patient loses the ability to hold urine. Every time straining of the abdomen occurs, when a person laughs, sneezes, coughing, lifts something, gets up, or squatting, or anything like. In this situation, there is usually a strong correlation between the stress urinary incontinence and the patient's physical condition. It's very important. The poorer the physical condition of the patient, the more prevailing is the incontinence. So people that are fit function better and have less of episodes of urinary incontinence than those that are not fit. Those couch potatoes is the very typical heavy incontinence patient. Obviously, there are many other circumstances that influence the propensity and the extent of stress incontinence. A patient with neurological condition, for example, general motor abilities, hormonal insufficiencies, and possible obesity, or for that matter, slenderness, are also quite influential and can be visible in those patients.
Is that because, Dr. Kulisz, the musculature around the bladder is lax? I mean, why would a slender person have a problem like that?
Well, the slender individuals, particularly young women that are heavily exercising, those women that want to have zero fat or very low percentage of fat, they are losing the fat, quote-unquote, cushion around the bladder neck. And the bladder neck is losing its mechanical support, and very often in those women, this bladder neck doesn't close completely. And this is the first dam, if I could put it this way. The second one is sphincter. So if the bladder neck doesn't close very well, then or is actually less it's losing this support, then it's much easier for urine to penetrate the structure of the urethra and leak out. Once they once they get a little fat, then this goes away.
Okay.
I mean, we've seen it in England, particularly among British population. There was the time of very young women that wanted to look like Diana, Princess Diana, and many of them really wanted to be that way, and they were overdoing it, and we've seen it in the Bristol Urological Institute quite a bit of this. So just a footnote, this is temporary and usually goes away as soon as they get some fat around. Okay. So let's talk about. Did I answer the question?
Yes, you did. Thank you.
Okay. Type 1 is usually an early stage. This is when occasionally when we have attack of cough or somebody in the company of somebody that says great jokes, we start laughing, and then sometimes we drop 1 or 2 drops of urine. It's not a big deal. We need to just watch it and be sure that this is not going to go any farther. It is an indicator that sphincter is unable to hold the urine well enough, and the bladder pressures exceed the abilities of sphincter to control it. Once again, it's not a big deal. Improve physical condition, everything will be just fine. It's nothing to be alerted about. When it comes to type 2, any straining activity may cause urine leak. So this is really something that person has to watch, and person has to do whatever she can, mostly she, to improve her physical condition, and once again this is going to go away. It's not a big problem. I'm a great proponent of non-surgical, non-medication ways to do it, and every one of us, or every woman for that matter, that has very little of desire even can do it very easily. This is not a problem. When it comes to type 3, this is the most advanced of those 3 types, and it's continuous leakage. And any minor effort, any minor change of position, getting up from the chair or trying to, say, bend over, sitting in a chair to get, say, remote control for a television set, this is causing a leak. Not to say, I mean, of course, any coughing, sneezing, or anything like it will do this too. And those people are completely dependent on pads or diapers, and they're very often very depressed and very lonely. This is a very important element because they are not, I mean, obviously they are not very social. It's very difficult to be social in such a case. And very often they separate themselves from the rest, even from their own closest family. So this is something to be really addressed. When it comes to intrinsic sphincter deficiency, this is the most severe form of urinary incontinence. So once again, I would consider it type 4 if there was such a thing. People basically don't have bladders anymore. I mean, anatomically, the bladder is still there, but because urine is dripping through it, bladder doesn't have any capacity, it doesn't have any function of storing the urine, so it's becoming very, very small, and actually is that there is no storage in it at all of any kind. Now, some of those people are going through surgical procedures that repair or improve the closure of the urethra. In this particular case, right after the corrective surgery, the patients are experiencing very frequent voiding every, say, 20 to 40 minutes or 30 to 40 minutes. This condition goes away as soon as the bladder gets stretched and gets to its natural volume, which is, depending on a person and the physical constitution, somewhere between about 400 milliliters all the way maybe even to 800 milliliters, depending how large the person is. So those are basically the things. So this is about stress incontinence. When it comes to urge incontinence, and I'm not quite sure if I pronounced it well, I would probably need to ask Sherry because she's the one that speaks English here. Urge incontinence is it is something very unusual because you cannot predict it very well. It is instant onset of an overwhelming urge to void. And normally, individuals affected with this kind of incontinence never have enough time to reach the bathroom quickly. This is very frustrating and very interrupting to normal functioning. Like patients with stress urinary incontinence, those that have urge incontinence also use diapers as preventive measure. This is the only way to handle it, for that matter. Now, there is a very specific type of urge incontinence that some urologists or neurourologists are referring to, which is door or key incontinence, which is basically somebody coming to the door, putting key in a lock, and peeing at the same time. This is literally a trigger for urge incontinence. So this is something that happens very often to people that have urge incontinence. There are basically two reasons for this condition. The one is involuntary bladder contractions. It is caused by the truth or instability, but it always involves some form of a trigger, be it the key in the hole, something that we need to do before we get to the bathroom, or sometimes something that is non-physical at all, a sound of running water or anything like it. And then another one is involuntary sphincter relaxation. It is called also sensory urge incontinence. I hope that you see it on the screen well. I was trying to show it in italics. And this is caused by vesicourethral hypersensitivity. This is the junction of the blood. This is the area of the bladder neck hypersensitivity. And this is something that is very difficult to treat, and the only way to do it is really to numb it. But once again, if this is numbed, then full bladder will cause a condition of overflow incontinence. It's kind of it requires some experimenting on the part of the patient to see which one, or how to do it, and how to adjust medications for it. It is commonly seen in older women. It is a transitional form and may also be associated with bladder infections to a much greater extent than stress incontinence. Now, comment to it. Bladder infections always create some inflammatory conditions there. But this is not the only reason for inflammatory conditions in the bladder. So anybody that has urge incontinence should be evaluated for inflammation of any part of the bladder, particularly the bladder neck. It is common that once inflammatory condition goes away, then urge incontinence goes away too. Now there is a footnote number 2 that is not on a slide. Most infections most bladder infections, most vesical infections are not native to the bladder. They are native to our dental care. So those patients that I've seen that had bladder infections, I was usually sending to a dentist, and as soon as the dental infections, those subclinical infections in the mouth, somewhere in the pockets of their gums, was cleared up, the urinary infections were clearing up too. So for wow. Those that are listening, please do remember that our mouth is full of various bacteria. Some of them are temporary, as we say, eat in a restaurant somewhere, and some of them are more permanent, that are somewhere in the gums or somewhere in the pockets. So as soon as those sources of subclinical infections are getting cleared up, the urinary infections or bladder infections are going to go away. Some of us that had teeth that were extracted may have pockets of infection that is grown into the cavity from which the tooth was removed. So in this particular case, the secondary surgery needs to be done, or revising surgery to clean it up and close it surgically, properly, or sterilely, to take care of it. And most commonly, before you even think about putting yourself on heavy-duty antibiotics or anything like it. Just address your dental care, and maybe this is all that needs to be done. Do you have any questions about it?
Yes, that is very, very interesting, Dr. Kulisz, because I was speaking with someone at a conference, and he treats cancer patients, and he brought up a similar observation, and apparently it has found out to be true in several cases, that several cancers that they found out have a correlation. I don't know if it's a cause and effect, but people with certain tooth or mouth problems or infections, there's a direct correlation with cancer in their bodies.
Well, I believe that this is the case. It's simply because there is in Europe we have a whole science that links inflammatory conditions to cancer or with cancer. There is a strong correlation of the two, and usually if there is inflammatory conditions that where etiology is infection, then usually removing the infection substantially improves the chances of getting rid of the cancer or cancerous growth. Maybe I should put it this way. Right. So that's basically all there is to it. All right. Yes. So let me go to another slide then. Mixed incontinence, it's basically a combination of stress and urge incontinence. And usually when stress incontinence is taken care of by various means, the urge incontinence becomes more prominent. Urge incontinence is in a way in the background of stress incontinence, and very often is not visible until stress incontinence is taken care of. This kind of incontinence is commonly seen in older women, and usually Kegel exercises or some physical exercises that address the tonus of the anterior vaginal wall, this part of the muscle tissue that separates urethra from the vagina. This is usually taken care of. It's not very difficult at all. And the overflow incontinence, this is the one that we talked about, it's simply a condition that I consider really a retention, but once again, in urology, this is considered to be incontinence. So that's basically how it is. It is most counterintuitive condition since this is actually a urinary retention. Let me go further. You see, there is some disagreement how to qualify urinary incontinence, and for many practitioners, it is really a symptom, not really a condition by itself, and it is usually associated with aging. Now, this is my comment here. I would like everybody to know, folks, we deteriorate as we get older, but age is not an indicator of health, and this includes incontinence. So if we take care of ourselves, a lot of health problems that are usually associated with aging are never going to get to us. I always tell this situation that almost sounds like a joke, where my wife and we are in our mid-60s. We have been denied health insurance because, once again, we are in mid-60s and we don't take any medications. So the underwriter actually stated that, well, I think that you are not credible because everybody at your age should take some medications. Well, we don't. Okay, so and any one of you that is of our age or similar that doesn't take any medications, congratulations. I think that you are doing very well. Mm-hmm. So now there is also perception. Incontinence to some people is really a very major problem. And once again, those people that have dreams, that have a strong character, that have something to do, this is usually a little nuisance. To others, this is a major problem. So once again, everything is a perception here. Let me go to another slide. Let's go to causes of incontinence. Well, we addressed already causes of bladder infections and possibly the urge incontinence. But such a major problem of incontinence, specifically here in the United States, is obesity. I don't know if you've noticed it, but we are the country that uses the most of the world resources of low-fat diets, and yet we have the largest bodies in the world. So this is something that probably we should think about. The other one is anatomical abnormalities. It is malpositioned or absent uterus, which is usually a very substantial element simply because it holds the bladder in the proper position. It's a cystocele, fistula, a weakness of the anterior vaginal wall that we have talked about already, and urethral sphincter deficiency, or what we consider a weakening of the pelvic floor. This is this membrane that holds our body, internal body in a way, that in pelvis. So what happens is that this should be relatively flat. There shouldn't be much of the caving of it, if I could put it this way. But when we get less physically active, this is becoming a sac and everything hangs down. The other one is iatrogenic causes. This is elegant way to say that somebody gave us something that really messed us up, that caused us a health problem. And this is very common, particularly at the age of very complex medications, of very difficult and unpredictable side effects. Incontinence very often is a side effect of such medications. And another one is gynecological surgeries. This is massive. This is something that I cannot tell you how important it is to be really aware what may happen if you are planning gynecological surgery. So this is, I mean, it's between the patient and the doctor, obviously, and the final decision belongs to the patient. So this is something that people should remember about.
Is there something the patient can do to minimize that side effect?
You mean the surgery?
Well, I mean, if she does go ahead with the surgery, is there something she can do to reduce the risk of incontinence happening?
Well, you know, it's very difficult to say simply because this depends on the condition of the patient. Usually, the better the condition, physical condition of the patient, the better the outcome of the gynecological surgery and less chance of being impaired. Nevertheless, I always tell people that, you know, we have this elegant language, you know, surgical procedure, minimally invasive surgeries and stuff of that sort. Folks, there is nothing minimal about surgery. Somebody sticks a knife in you and you have to heal from it. Okay, no matter what the reason is, it is a major wound. So do remember that if you are undergoing any kind of surgical procedure, be it elective or necessary, there is always a risk that something is going to happen afterwards. And I can give you this on the side of men, those that go through a prostatectomy, radical prostatectomy, very often become incontinent simply because in the process of removing the prostate, there is oops, and oops is removal or damage of the sphincter that is below the prostate. And from that moment on, men start leaking. So you never know. Okay.
Right. What's a cystocele?
I'm sorry, could you repeat it?
What's a cystocele?
Cystocele is a condition in the bladder usually, or in the urethra, where there is the pocket is created, and this pocket actually obstructs the functioning of the closing mechanisms. And the fistula is the basically connection between the bladder or the urethra and vagina, where actually urine leaks through, so there is no closure to it.
Okay.
You know. Let me go to another slide. National Association for Continence, NAFC, estimates that 25 million adult Americans experience transient or chronic urinary incontinence. There's about 85% are women. I'm just making you aware of it because, I mean, I'm kind of repeating it again because this is a major problem. And most of this major problem can really be resolved taking care of yourself. 1 in 4 women over the age of 18 experience episodes of leaking urine involuntarily. Experience episodes. It doesn't mean that it happens all the time. It happens occasionally. But this is a signal that this needs to be taken care of. So let me explain this later. About 1 in 5 adults over the age of 40 have overactive bladder or recurrent symptoms of urgency. Urgency or frequency. This is when the bladder is small and fills very, very quickly, or when the bladder is not evacuated completely, so the amount, the volume that is left to fill is very, very small, so people are going to the bathroom very quickly. Now, when you are alone, when you function on your own and you're independent, then you can actually function quite well with this. But when you are in a nursing home, this is something that is very, very major. And nursing homes usually don't care much about it, so they put people in diapers and leave them alone. This is very, very detrimental, not only to physical health and skin conditions and the like, but primarily to depression, to their mental state, which can be very, very detrimental. When it comes to elderly, 60 years old or older, well, this puts me into this category, I suppose. About 35, up to 35% of people living alone or living in the community are affected by incontinence, and about 50% of about 2 million people of nursing facility residents, 1.8 million it is estimated right now. This is very interesting that you may see that about 10–11% of urinary incontinence at admission to hospital, report this at admission to hospital, but 23 in discharge. So what happens is that hold on a second. I'm sorry, here we started having some telephones flashing here, so I apologize. And the estimated 50% of elderly suffer from urinary incontinence. So that's basically how it is. And once again, this is nothing that cannot be taken care of. $30 billion a year right now. This is the cost of incontinence in the United States.
Wow.
And this is recognized as one of the major causes of putting people in the institutions. And this is stated by clinical practice guidelines, this Agency for Healthcare Policy and Research. This specifically the agency that controls or actually collects data on various health conditions in the United States. Now, the most important thing of the incontinence is emotional distress. It is physical distress too, but emotional distress. It is very, very important to address it and be aware of it, because we lose physical abilities if we are losing dreams and if we are losing ability to plan ahead and feel well. So what happens is that this creates situations of living in isolation, not reaching bathroom on time, and basically, it's very limiting our lives, including employment. When it comes to treatments, there are two groups: non-surgical treatments, which is naturopathic. This is what I do. Physical therapy medications, legend medications or prescription medications, and combination of those three, and non-surgical occlusive devices and pessaries, and we are going to talk about it later. When it comes to surgical methods, there's various kinds of suspensions, medications, bulking injections, and implantable occlusive devices. Those are something like implantable sphincter. That's very, very common. When it comes to side effects, scars, infections, retention, urinary retention, necessity of revising surgeries, often very high cost. So when it comes to those non-surgical methods on the left side of the slide, practically no side effects with exception of side effects of medications, synthetic medications. So the left side definitely is one to start with if somebody would consider it. When it comes to, once again, Agency for Healthcare Policy and Research Clinical Practice Guideline, urgent incontinence characteristics, the truth of instability, behavioral treatment, and sometimes fluid management. They list here fluid management as a treatment. Folks, this is not a treatment. This is just management. I don't want anybody that has incontinence to stop drinking, because you definitely don't want to be incontinent and dehydrated. Right. This is not something that you would consider. When it comes to stress incontinence with normal post-voiding residual, that means without urine left in the bladder and no complicating factors, this is relatively easy to take care of. And you don't have to go to synthetics, actually, or tricyclic antidepressants. You can take care of it quite easily, and I'm going to show you a few slides down the road here how to do it. Here's the Pelvitrax. Pelvitrax is a program that I developed based upon my book, Drips, Leaks, and Low Spirits, Women's Guide to Bladder Control, Infections, and Depression. Well, I wrote this book actually at the request of my wife because we had this situation that we had parties at home from time to time, and I was cornered usually by her friends, female friends, asking me what should they do. Well, there was kind of a bad way to run a party, I suppose. So she said, honey, write a book. And so I did. I'm a good husband. When it comes to Pelvitrax, inclusion criteria are very simple. Stress urinary incontinence, urgent incontinence, secondary to light, detrusor and stability, or mixed. This covers probably 80% of incontinence cases. When it comes to patient evaluation, and this is something for those that are listening to us that they can actually evaluate themselves, there is in-depth assessment of the patient's condition. Mental, do I want to do it, or is it fine that I am incontinent and I function like I do? Physical, am I too couchy potato or am I active? And urological, voiding diarrhea, electromyography of the pelvic floor, this may be needed, and uroflow and post-voiding residual. Sometimes this is not necessary, but definitely important thing is be infection-free and in good spirits to enter the treatment, whatever kind of the treatment it is going to be. When it comes to incontinence complex, and that's how I perceive incontinence, that this is really a complex issue. It consists of depression. I put here sub-items that show how we naturopaths or people of more natural branch of health, how we deal with that. Depression, St. John's wort, B12, synthetic medications if they need to be given. When it comes to obesity and constipation that are quite common in incontinence, weight loss, change of eating patterns. Instead of eating bulky foods, we eat less. However, we eat nutrient-dense meals. This is very important. We don't need to eat a lot to have enough of nutrition. Now, restoration of gastrointestinal tract. This has two elements to it. One of them is that those nutrient-dense meals are basically digested and absorbed to the bloodstream. And the second one is that we start evacuating correctly so we don't need to go to be constipated. And the last one is detoxification. Very often when it comes to proper functioning of our physiology and neurology, this is disrupted by some toxins that we have, and going through detoxification, there are many types available. This very often clears the problem. When it comes to infections or interstitial cystitis, which is probably the most disturbing part, the most disturbing form of infection, the first one is to lower bladder pH. Urine that is alkalic is an invitation to infections. So I know that there are those talks that you don't have body acidic and all this stuff, and just skip it. It just doesn't work. Bladder is, urine in the bladder is acidic. That's how it is. And the more acidic it is, the less chances are that person gets infected or actually grow infection.
So
now,
the blood, sorry about that. So the blood should be a little bit more on the alkaline level, but the urine should be on the acidic level. Is that what you're saying?
That is correct, yes. And our physiology keeps control over it very, very well. I mean, we have this wonderful physiological process that controls our body fluids, or acidity, or actually pH of our body fluids. And whatever needs to be alkalic is alkalic, or actually about to be alkalic, somewhere about 6.5, 7, 7.4, 7.5. When it comes to urine, normally if you have a person that has urine of about 6.5, you better check for leukocytes, for signs of infection. If you have a person that has urine of about 4 pH 4, then you don't have to bother with this. You can be absolutely sure that there is no infection.
And vitamin C, apparently, I understand, is good to keep the urine more acidic.
That is correct, particularly among people that have tendency to have urine on the alkalic side, like beer drinkers, for example. Then putting, say, 5-6 grams of ascorbic acid or vitamin C does well. Also, cranberries, non-sweetened cranberries or cranberry juice does excellently. When it comes to interstitial cystitis, this a little bit more complex, but usually it is taken care of by vesical instillations. Basically, it's a catheter put in the urethra, very thin, pliable rubber tubing, put through the urethra to the bladder, and either colloidal silver or argentum nitricum, it's silver nitrate, solutions are instilled there. There is also DMSO, dimethyl sulfate oxide, about 10% water solution, does terrifically well with interstitial cystitis. It's absolutely excellent. We are using it in Europe all the time, and it's practically not used here in the United States. It's very safe, very effective, and usually 4 or 5 infusions like that take care of it. Take care of interstitial cystitis. So it is a curable thing here. When it comes to restoration of bladder control habits, folks, this is a very simple thing. If somebody was incontinent for, say, 2-3 years, then all of a sudden we don't care about our bladder control habits simply because we are dripping all the time. So we have to stop dripping. Get the diaper out. Stop using diapers and start controlling your bladder, thinking about it. And eventually it's going to become a habit of normal controlled bladder. Now, any course of treatment must include all of those elements to be successful. So, once again, starting from depression, people that are depressed don't get cured. Go ahead.
I'm particularly interested in the mental and the emotional aspect. Now, from your presentation, you mentioned that urinary incontinence can be a cause of depression. Now, can it go the other way? Can depression and other mental negative emotions, can they lead to urinary incontinence?
Yes, actually, there is a scientist in Sweden, Anna-Lena Berglund, that wrote much about it, and actually I have some fragments of her opinions in my book. That she was talking about depression, correlation depression and incontinence. It actually goes both ways.
Okay, thank you.
Actually goes both ways, yes. Mm-hmm.
And is that, can you give us the name reference for people who are interested to go to?
Well, you can Google her, Anna, A-N-A, Lena, L-E-N-A, Berglund, B-E-R-G-L-U-N-D. Anna-Lena Berglund from Sweden. She's a urologist, and she did a lot of it. And you may try from bookshelves.com, you may try to get a book, Drips, Leaks, and Low Spirits. I think that they may still have it. And in this book, it's not very thick book. It's about 110 pages, I think. That there are some fragments of my interviews with her at the time that I was teaching urology or elements of urology in Sweden in Umeå University in Umeå. Okay. So, well, we are working right now, or I'm working right now on updating this book. So this book should be released again in about probably 6-7 weeks, something like it. We'll see how it is going to be. It is going to be announced on myfoodforhealth.com, our website, myfoodforhealth.com. There will be an announcement there. Okay, let us continue then if there are no more questions.
Sure.
Okay, treatment of urinary incontinence. Usually it's about 6 weeks, very rarely longer. It's usually electromyography, assessment of pelvic floor, electrode stimulation, uroflow, and those things. They're very clinical stuff. Non-invasive or very little of invasive, no blood field. It's very easy and gives patient full control. This is very, very important. The way I approach incontinence, it is a team sport, if I could put it that way. It is patient that plays 80% of it, and I play 20. The control is on the patient's side, and I am just an advisor what to do, because no matter how much I may try or physician may try, if patient is not motivated to do it, nothing is going to come out of it. When it comes to part 2, usually a patient that is leaving incontinence treatment program, good program should leave with means to maintain continence and exercise. So there are some exercise devices, some means to stay dry. And what we were doing is that we are monitoring patients periodically, and our nurses were calling them and verifying how they are doing, and if there was necessary, we are bringing them back to the office. But overall, there was pretty good result. We had pretty good results with that. Once again, because of motivation and because that was non-surgical approach to it. So the control was in the hands of the patient. Now, when it comes to scheduled toileting, I really don't like this all that much, simply because, you see, if we are going to put a patient in a condition that patient has to go to the bathroom every 3 hours or every 2 hours, every 1 hour, then what happens is that there is a side effect to it. And side effect is that bladder gets smaller and smaller and smaller to accommodate only as much as is needed to go to the bathroom every hour or every 2 hours. While normally, patient, you shouldn't need to go to the bathroom any more frequently than probably every 3 hours or so. So the reduced bladder volume that may increase the frequency of voiding is very, very important concern here. When it comes to bladder retraining, well, we need to increase the length of time. So this way, bladder gets larger. So this requires a lot of strong will to do it. It's not always very comfortable, but provides excellent results. There is nothing better and nothing more rewarding than the fact that you can be absolutely sure that you are dry and you don't have to look for every bath. Incidentally, I have to tell you that people that are incontinent usually know every single bathroom in the radius of about 10-15 miles where they live. So it's kind of a side effect. When it comes to pelvic muscle rehabilitation, well, it's basically pelvic muscle exercises. Some people call it Kegel exercises, although if you go to Kegel's writings, you are going to find out that this is probably not exactly what he had in mind. Nevertheless, the rule is, if you don't use it, you lose it. If you don't exercise the muscles, those muscles are becoming very flaccid and non-responsive. So this is very important that may be used alone or in conjunction with biofeedback. This is important to remember that. When it comes to pharmacological treatment, well, I don't like it simply because it generates usually substantial side effects. Dry mouth is one of the least probably invasive. And some drugs, and I'm not really willing to comment on it all that much, may even contribute to incontinence. So this is very important that pharmacological treatments address symptoms, not causes. So just keep it in mind.
What's the commonest drug they use to treat incontinence?
Could you repeat it?
What is the commonest drug out there that is used to treat incontinence?
Well, there is a whole cholinergic drugs. There is a whole family of those. There's Detrol XL. There is quite a number of numbing drugs for stress urinary incontinence and urge incontinence. Once again, they are not really, I didn't find them to be very beneficial.
Got it.
When it comes to surgical treatment, this is really out of my department. It's very invasive, it requires healing, and the side effect of surgical treatments of incontinent patients is that the passages may become over-tightened, say the bladder neck suspension, and as a result, patient will go attention. So this is a side effect. And when it comes to injections, the bulking injections, well, collagen injections around the urethra work for some time, but collagen gets reabsorbed by the tissues and eventually this goes away. There were some plastic injections, like little plastic spheres, that were used, and eventually they ended up in the bloodstream, so doctors got very, very scared. When it comes to implantation of artificial urinary sphincter or stimulators for that matter, I don't know. I wouldn't do it. And if that was my wife, I wouldn't ask her to do it either. I mean, I would ask her not to do it. So that's basically it. When it comes to those that are incontinent, National Association for Continence has recommendations that for those people whose incontinence cannot be cured, or for those who are awaiting treatment, there are other devices or products to help manage incontinence. These include catheters, pelvic organ support devices, those are pessaries, urethral inserts, and the like. I would like you to read this sentence again. For those people whose incontinence cannot be cured or those who are awaiting treatment. Those two groups of people are basically lumped together. What's the difference? And they were saying that actually we can do this by inserting a pessary. This is $90 thing. It is in the form of a ring or a ball or a cube or whatever they are. There's very many forms that is put intravaginally all the way up to support the bladder neck. So the bladder does not prolapse. And once those things are in, there is no more incontinence. And they can be there forever practically. And any woman can do it. So I'm telling you this because you see, if we are losing our abilities to see text in the book, and we need to have reading glasses, we are just putting reading glasses. We don't operate on our eyes. When it comes to incontinence, before anybody will go through surgical procedure, I would suggest use pessaries. Talk to your gynecologist, demand it. So go to the internet, look for pessaries. This is spelled P-E-S-A-R-I-E-S. It is either single S or double S, P-E-S-S-A-R-I-E-S. And look it up, and you will be very, very surprised how well those things work. So that's pretty much it. And other than that, I thank you very much. If you have any questions, please go ahead. And thank you very much for listening to me.
Wow. Thank you very, very, very much, Dr. Kulisz. This has been very, very informative. I think it's very important that you address all the different areas. And I know most MDs or healthcare professionals will not talk about depression or the other emotional aspects that can really trigger or worsen the depression. And of course, the part about the teeth, I had no idea that there was a connection. So that's really good information to know. So folks, if you know people who are going through those things, this webinar will be recorded, or it has been recorded, and the slides and the information, you can go to our website. The address is at the bottom there. Dr. Kulisz, this is your web address, right? This is ENHC Center?
ENHcenter.com.
Okay.
This stands for European Natural Health Center.com, ENHcenter.com. The other address that we have is myfoodforhealth.com.
And that has a lot of information on several different topics, right?
That is correct. This website has information and has links to some other websites with information on incontinence. That is correct.
Great. Do you have a few minutes to answer some questions?
Go ahead.
Folks, just remember, if you're new here, there's a panel to the right of your screen, a blue panel, and you can type in your questions. Someone asked you to explain DMSO again.
Okay, DMSO stands for dimethyl sulfide oxide. DMSO is a solvent that is extracted in the process of cellulose production or paper production. And what happens is that it's used in medicine, and actually all kinds of medicine, include veterinary medicine. DMSO is an excellent solvent that carries through membranes, through tissue membranes, whatever was diluted in it, the vitamins or amino acids or anything else. But also is incredibly, greatly antibacterial and antiviral. So small the weak solution, say 5, 10, 15% of DMSO in water, can be used terrifically well to wash wounds, to wash whatever skin problems are, to clean them up and help healing. Now, there is also one more thing, that DMSO is used as a first line of defense against strokes in many people in other countries, where DMSO, full strength of DMSO, is put on pulse points of the person that has a stroke or has problems breathing, and it restores the breathing ability and oxidation of the bloodstream. So actually works very, very well. Okay, and then there is one more thing, that there is a book, DMSO Miracle, I think, if I remember correctly, and we have it, as a matter of fact, in our clinic. I think that this title, DMSO Miracle, and it's quite a thick book, and there's a lot of information about DMSO. So just use it. It's a great thing.
Okay. Thanks. Sherry, any questions over there?
I have not seen any more come in at this point. Just a reminder again that David had mentioned you guys could type in questions in our little box if you would like to ask any.
Well, it just simply means the presentation has been very, very clear.
Okay, here's one that came in. It says, my mother has a cystocell bladder prolapse. Her bladder just shows through the vagina. Would this preventative, I guess it's asking, are there preventative methods or things that would help?
Well, try pessary. It's just a simple thing. Push it back. This has to be done by a gynecologist, probably, or urogynecologist, and put it back, and then put pessary to support it, and maybe that's all that needs to be done. I definitely would start from this.
But wouldn't the pessary in place for a long time be a focus for infection?
No, it's not, actually. I didn't see it, and actually there is a substantial amount of literature in Germany that addresses pessary, or basically those pessary-like devices. And actually it works very well. There is no infections. It actually works very, very well.
Okay. Someone asks, what is the name of the website where the book can be ordered?
I have no idea. If you would like to wait a little bit, I probably would find out, but I have no idea right now. It will take me probably another 2 minutes to find it.
Someone, the same person who asked the question about the pessary said that I guess that would be the doctor. They said that because of the age, the pessaries would not be a solution.
Well, it's the point of view. I have tell you that I have yet to see a person that wouldn't qualify for pessary if pessary was correctly matched. Now, there may be some other considerations. There may be some anatomical conditions where pessary is not indicated. So it's very difficult for me to make a definitive statement about it. Nevertheless, the rule is try to match it with pessary before you stick knife into it. Okay.
Go conservative.
I'm not quite sure what book that was a question about. Was it a book, Drips, Leaks, and Low Spirits, or it was a book about DMSO?
I think it was a Drips, Leaks, and Low Spirits. But folks,
Drips, Leaks, and Low Spirits, we don't have it available right now. I think there is a bookshelf.com is the website from which it can be ordered. And they just monitor the website, enhcenter.com. And there is going to be an announcement posted. This book should be released in about 6 weeks or so.
Okay.
Or re-released, actually. That will be 4th edition right now.
I know you probably covered this during the webinar, but someone asked again, what would you think causes dribbling when coughing or running? And what would be a good thing to do to help that?
Well, how much of a dribbling? This is form of stress incontinence. And now the question is it a so-called clear stress incontinence? is it the only weakness of muscular structure, or there are some secondary element of it, like, say, infections or inflammations? Okay, there is one more very important that my wife is sitting right here with me, and she just mentioned food allergies. Yes, this is very, very important element. A lot of people are reacting with dribbling or dripping, actually, I should say, because of food allergies, and as soon as allergy goes away, the incontinence goes away.
Can a person, as we age, do decreased hormone levels have anything to do with incontinence?
It may. It depends how the situation works. I like people to attend to their hormonal needs by means of proper nutrition, where the steroid pathway, the one that leads from cholesterol through pregnenolone and the progesterone all the way to testosterone and estrogens, is properly fed. So this way, the testosterone particularly has very substantial influence on quality of muscular structure. When this is going away, then obviously everything gets very, very flaccid. So there is a formulation called Cataplex B that we use that is very good in providing people with restoration of proper tonus of muscular structure. It has to be taken for about 4 or 5 months, but gives pretty good results. And there are several others in the natural apothecary that we have, that we use in our practice, that actually work very well. So if anybody has questions, they can call us, and we'll be happy to answer the question. Or the other option is that you can send email to info@enhcenter.com, info@enhcenter.com.
Another question. Now, the pessary is inserted into the vagina or urinary tract. Vaginally, how does that affect one's sex life?
It doesn't. If it is properly placed, the partners won't feel it.
Okay, great.
You had mentioned the pelvic floor muscle exercises. Do you have a recommendation for a source where people could learn more about that, or a website or something?
There are several websites about it, and here's what I would do. I would probably go to Google. This is pretty dynamic area, as a matter of fact, and Americans are very unusual people. I mean, I presume that most of us that listen to us, most of those that listen to us are here in the United States, maybe perhaps in Australia. Those are pretty independent folks. What I would suggest is that go to Google and Google it, and Google keywords pelvic muscle exercises or something to that effect. There's tons of devices for this purpose that if people want to do it. The other option is just exercise it by the mere fact that you know which group of muscles you are contracting. And I know that some people may not be aware of where the pelvic floor is, but there is a kind of a very picturesque, I suppose, definition of it, that if the patient puts 2 fingers in the vagina and contracts lower abdomen, so the muscle that contracts around those 2 fingers is the pelvic floor, element of the pelvic floor. So this way they can actually isolate it better, and then eventually they can exercise it, they can contract it and release it 10, 20 times every 2 hours through the day without sticking fingers into vagina, obviously. And then actually this brings terrifically good results. And on top of it, if they take something like Cataplex B or some other natural formulation to secrete more testosterone and improve the pathway of steroids, then they may have pretty good results.
Okay. Can a person test their own pH level of their urine? Is there a way to test that at home?
Yes, you can go to any nutrition store and buy pH strips. They are probably $5, $6 a roll. So you will have enough to test for the rest of your life, probably. Just, please, do not pay much attention to it. Generally, it should be acidic, but remember, your physiology is a very dynamic set of processes. So you will react differently to different stimuli. So you have ice cream today and you have steak tomorrow, and this actually is going to create different effects on pH. Try generally to have it on the acidic side, but don't get panicky if all of a sudden you are going to test 7 or say 6.5, something like it.
Okay, would that be any kind of an indication of bladder infection?
Well, it is only indication of the bladder infection if the person feels that there is a bladder infection. There's several things to look at. One of them is that there is a need to void. There is a burning sensation while voiding. The second one is that urine may be milky, kind of not clear. So there are several things to look for, but just focus on your health. You know, if you are going to have bladder infection, you will surely know. And then besides, it's very basic urine test for $10 at the local lab is going to tell you if you have infections, if you have leukocyte level high. So it's very simple to verify.
And one of the first things you would suggest to help keep the urine acidic and reduce infection load is vitamin C and the cranberry juice.
The cranberry is terrific. Cranberry contains alpha-D-mannopyranoside, which is the chain of sugars that are very specific physical-chemical properties. I see it works absolutely terrifically, and to the point that the Germans actually extracted, and they have their own extract of alpha-D-mannopyranoside for people to drink, and they are actually doing very well. So it is not here in the United States, unfortunately. But cranberry juice, unsweetened cranberry juice, is terrible to drink, but actually works greatly.
Isn't that so amongst many of the best nutritional products? It tastes terrible, but some of them.
Well, that's the way. If it doesn't taste well, it works.
Well, if you water it down, I buy it at my health food store, and I water it down, and I'll put maybe a little bit of xylitol or some of their natural sweeteners.
Oh, come on. You don't do this. You're just loaded. I mean, don't dilute it, because you remember, every time you dilute anything, acidic or alkalic, you always bring pH towards the center. So the trick is that if you want to have benefit of low pH in this particular case, then you drink it as it is from the bottle. Diluting it it brings pH to neutral.
It's going to be puckering up all day long.
Yeah, pucker up. There you go. Hunker down. Did you answer this question about my mother has cystocele bladder prolapse?
Yes.
Okay.
Yeah, we did that one.
Okay, how about this? Would a lot of sitting encourage incontinence, like truck drivers or soccer moms?
Well, no. Well, the truck driving is pretty much exclusively male thing, and men are very rarely incontinent. When it comes to women, generally sitting for a prolonged amount of time lowers the tonicity or tonus of the pelvic floor. So obviously, being passive or not exercising muscles causes muscle deterioration.
Climb this bleachers often.
Okay, so if there is a soccer mom, then climbing bleachers back and forth may actually help.
Yeah, it is an exercise. And squat while you're climbing the bleachers as well.
Yeah, probably.
Lower exercises while you're sitting there.
So would you say that when a heavy person loses fat and doesn't strengthen the muscles, the pelvic floor specifically, this would result in cystocele and incontinence?
Well, let me address, those are separate things. Let me tell you this. Any person that is substantially obese and incontinent should remember that if the person loses, this is actually my rule that I found out to work, that if a person loses half of the weight, the person is overweight, the person will be no longer incontinent. So if the person is 100 pounds overweight and loses only 50 pounds, probably continence is going to recur. Now, when it comes to prolapses, this is completely different story because they can be of very many origins or etiologies, and hysterectomy alone can be very prominent, may play very prominent role in it. But the rule is put bladder where it belongs, and all of a sudden incontinence goes away.
And pessary would be the first way to go.
Pessary by far is the best way to try, and may as well be the only way that's needed.
Okay. Someone says this has been a great, in capitals, great call, and how do we find the archives? And we'll work on it. With Dr. Kulish's permission, we'll probably make DVDs, and then we'll let you know. So once you've registered for this webinar, we'll let you know how to access the archives and the recordings. Okay.
And very well. Don't forget me. Get me the copy of it too.
Oh, absolutely, Dr. Kulisz. Absolutely. I can't run away from you. We live in the same town.
But it's kind of funny that two guys with foreign accent are speaking on American, doing American webinar. It's really
it's a small world.
Yeah, it is, isn't it?
Yes, it is. Well, once again, I just want to thank you, and I know Tommy, your wife, has been in the background. Tommy, hi again, and thank you for nudging him and giving him pointers here and there in answering the questions. But we appreciate both of you, and thank you, folks, for joining us on the webinar, and we wish you a wonderful night and day if you're in Australia, and we'll see you next week.
Very well, then. Thank you very much, everybody. Good night.
Good night.
Thank you.